Hello, everyone. My name is Corey Thornton. I'm the senior editor for the Open Minds Market Intelligence team, and I would like to welcome you to today's Circle Elite Executive Roundtable, preparing for CalAIM, where have we been and where are we going, a California update. Today's roundtable features Dr. Stuart Buttlaire, Regional Director of Behavioral Health and Addiction Medicine at Kaiser Permanente, Dee DeWitt, Senior Associate at Open Minds, and Richard Lewis, Vice President at Open Minds. Before we get started, I have a few housekeeping reminders. Your audio will be muted for today's briefing. However, we encourage you to submit questions. If there is time at the end, we will get to them. Otherwise, I will be reaching out separately to everybody who's asked a question with your answers. And finally, the slides and recording from today's briefing will be available on the Open Minds website starting tomorrow. And with that, here's Richard.
Thank you, Corey. Let me make sure I could get my slide thingy to work here. Good morning, everybody on the West Coast, and good afternoon, everybody on the East Coast who's attending. We're really happy to do our first quarterly Preparing for CalAIM live webinar, and it's part of our quarterly Elite Roundtable series that we do featuring California provider organizations, county behavioral health systems, and health plans as we transition here in California to a new system of delivering Medicaid services to members here in California. I'm happy to be joined by Dee and Dr. Buttlaire, and our topic today is preparing for CalAIM. Where have we been and where are we going? Kind of a California update. For those of you who are not from California, CalAIM is California Advancing Innovating Medi-Cal, and that's really our 5-year initiative here to move our Medicaid system, which again is Medi-Cal here in California, to a more coordinated population health and whole person care model and delivery system, delivery of service delivery, and moving this really from fee-for-service more to a performance and value-based reimbursement model. On the map on the side, for those of you not from California, California is divided into 58 counties, and every county behavioral health system in California is a managed care plan for Medi-Cal. For our safety net population, those are folks, adults with SMI and kids with SED. As I mentioned a minute ago, it's a 5-year initiative, and here started back in 2019. We had a little bit of a pause in 2020 because of COVID, but it went right in. Things started right back up in 2021 with our move to moving the needle on our system transition. The goal of CalAIM is to reduce system complexity, increase flexibility, improve quality of care, and drive system transformation through the use of value-based initiatives and payment reform. The goals of CalAIM are really to identify and manage comprehensive needs through whole person care approaches and social drivers of health. And we're going to talk a little bit and hear from Dr. Buttlaire from Kaiser Permanente more about what that means and what that looks like. Improving quality outcomes, reducing health disparities, and transforming the delivery system through value-based initiatives, modernization and payment reform. And again, our system here in California is very complex and really trying to move more towards a seamless, easily accessible system for Medi-Cal beneficiaries. Where we have been, I think for us in California, this is a huge change that we've seen something this probably in the over 30 years that I've been in behavioral health care here. 2022 was really the start of CalAIM for us to really see some of the first initiatives coming out, and that being health plan and managed care plan contracts available for providers and community-based organizations, social service agencies, and FQHCs to be able to provide enhanced care management and community supports that address social determinants of health for our complex Medi-Cal populations here in California. Like any new initiative, there's challenges, and I think the challenges we saw were both for payers as well as providers. For the providers, a new certification process of submitting letters of interest, a new certification application, submission process, credentialing, training, a contract process that was foreign to many providers who have not had a health plan or managed care plan contract, or who didn't have any experience working with developing with reimbursement based on case rates as opposed to just direct fee for service, case rates and bundled rates. For providers, I think again the contracting process was a little difficult. It was difficult for the health plans. They had never contracted, many of them with providers who were never Medi-Cal certified, didn't have that kind of experience. Credentialing was a heavy lift for some, as well as meeting the new data requirements that the plans required to provide care management and the community supports. Providers had to adapt to a new authorization, claims and billing processes. For many providers who were in multiple counties, working with multiple health plans that all had different contracting processes and systems and requirements, meant a quick learning curve for providers, as well as the learning curve that the health plans would tell you for them working with a new population of folks that are more complex as opposed to the mild to moderate, and those that and a different type of service lines. Enhanced care management and the community support services are new to us here in California. Lost my train of thought. But in any event, we'll talk a little bit about some of the successes of the rollout. And in a report, in a meeting with Anthem, they shared with us last August their rollout in Anthem, now known as Elevance, of the transition of the successful transition implementation of the health homes program and whole person care pilot populations by 2022. Our CalAIM initiative and our whole person care approaches and integrated care approaches here are based on health homes program and whole person care pilots that providers in our county systems participated in a few years ago. And those populations are very complex populations that Dr. Buttlaire will talk about, where the target populations that were moved into starting January 1 of last year, these new programs. Anthem reported back in August, which is pretty good start. 4,500 members grandfathered in by January 1, over 6,200 authorizations by early fall, and over 90 contract providers. And I'm sure those numbers, and I know those numbers have increased since last August. And that's for the enhanced care management program. For community supports, Anthem had 1,400 health homes program and whole person care enrollees grandfathered in by January 1, 2022, over 2,000 authorizations by early fall, and 107 provider organizations. So that's where we've been. We're going to talk a little bit about some of the new things that we're looking at for 2023, as well as the new contracts that will be available starting in July of 2023 for enhanced care management and community support services for kids and adolescents. With that, I'm going to introduce Dr. Stuart Buttlaire. As Corey mentioned, is the Regional Director for Behavioral Health and Addiction Medicine for Kaiser Permanente here in California. Dr. Buttlaire, you have the floor.
Thank you, Richard. And welcome this morning for those of you in California. I get to start with a disclaimer. These are my own thoughts, not approved or sponsored by Kaiser Permanente. My experience with Medi-Cal actually goes back 30 years with Kaiser and in developing our direct contract with the state, as well as our carve-in contract with Solano County. Before that, I actually came from community mental health, where I developed a number of programs working with the county for our Medi-Cal and indigent people. So it was a pretty easy fit for me when I came to Kaiser, for them to actually have me be the lead person for Medi-Cal, and that's continued over the years. I also was appointed to the stakeholder groups for CalAIM by the state, and actually worked on the tools that the transition, as well as the screening tools in Medi-Cal. So I have quite a bit of experience with working with the state and some of the nuances of some of these programs that are rolling out. I want you to be thinking through this, our conversation, because this is going to be a conversation as well as a presentation. Where do you fit in? Where do you as an organization or provider or health plan fit into CalAIM? And where are your opportunities and perhaps your challenges currently? So keep those things in mind as we're talking about things. And so, I think of my experience at Medi-Cal and now in CalAIM. I think of Medi-Cal as Samuel Johnson said about second marriages, is the triumph of hope over experience. And sometimes, from time to time, actually, hope does triumph over experience. So keep that in mind and have that sort of positive sense that actually things can improve. And there's been an enormous commitment on the part of the state of California with really good intentions to really do help the indigent and Medicaid population. Next slide, please. So this is overwhelming. These are the numbers of initiatives and legislative regulatory requirements that are impacting health plans, hospitals, and those that are involved with this enhanced programs. We're going to focus today on probably four, which is payment reform, no wrong door, screening and transition tools, and the ECM program, particularly for those with serious mental illness, as well as the youth. Next slide. So, California is moving its payment reform from HCPCS, which are Healthcare Common Procedure Coding System, and to CPT codes, which are the current procedural codes. Why would they do that? And what's involved with CPT codes? Well, these CPT procedure codes have been developed by the American Hospital Association. Why is that important? Because the American Hospital Association is involved with professionals, right? It's a billing system for professional providers, where the HCPCS were a little bit different than that. There's still going to be HCPCS level, what they're calling level 2, which has to do with supplies and equipment and other products. But generally, it's a movement towards CPT codes, then eventually value-based, whether that's going to be prepayment or payment for outcomes. It's a movement in that direction. Why is that important? Why are these CPT codes important for you? Because I really recommend that you look at your staffing. It's really important because there's a differential pay under CPT codes for those who do peer support versus social workers versus MFTs versus psychologists versus psychiatrists. It's a professional coding system. So you need to look at your staff. Take a look now at the ways in which you are billing and which providers you're billing for, and translate that into CPT codes and looking at your staff mix. That becomes more and more important in your staff mix, because you can bill differentially depending on the staff that you have. I really recommend, and I've been working with an organization was looking into this, is the Cal Mesa, California Mental Health Services Authority. They have a really nice website, and they have a tool that will allow you to take a look at how much you might be paid for the services you're providing now, including the providers, and then the providers who that you might transition to. So take a look at that. Again, I recommend you look into the CPT codes and your staff mix. You may decide you want to hire a psychologist who can do some testing because you can bill more for that. You may decide you want to have a PA or a nurse practitioner or some other provider that you may not have wanted to do before because they were too costly. They may not be now. They may actually help you gather more revenue. So again, we're moving to CPT codes, and then SDOH. What is that? That's social determinants of health. I'm going to show you a slide about that, but the state is really committed now to those social determinants of health because they know if you look at zip codes throughout California, you can tell which populations are underserved and are ill health and actually costing more. So they're really focused on helping people take care of their social needs and other needs in order to be able to have a healthier life and support Medi-Cal. Any questions about that? Is there any discussion among us about this issue? Or should we go on? Any questions? Okay, let's move on. So some of these are some of the codes that managed care plans are now going to be paying for that they weren't before. Again, CPT codes, family therapy without a patient in the room. Think of that as being collateral contacts, without the patient being in the room. Family psychotherapy, conjoint therapy, multiple family group psychotherapy, interactive complexity. Look into interactive complexity. Think of the kid that you're sitting across from. No matter how many questions you ask that youth, he's not going to answer you because and you have to get some more information about that kid in order to make a good treatment plan. That's interactive complexity. Those are the kind of things that you need to think about. Hypnotherapy for the first time is being included. So that would be something that you use, as well as all the alcohol, tobacco, substance use screening and assessments, brief interventions required now under Medi-Cal for age 11 and up. That was not the case before. Also, all those procedure codes associated with medications for addiction treatment, MAT treatment, that are considered non-specialty mental health services are actually billable to the managed care plans now and have been for a while, but now there's a real emphasis on providing that service. I know that, as we know, that substance abuse rehabilitation is carved out to the Medi-Cal mental health plans. They're carved out of the managed care plans, but MAT and screening and transition are all billable to the managed care plans. Hopefully that's helpful information for you. Next slide. Excuse me. So I think of the DHCS priority SDOH codes, these social determinant codes, I think back to my college days and thinking about Maslow. Remember Maslow? He called it the hierarchy of needs. So these are basic needs that really influence people's lives in order to have their psychology and also influence their psychology. These are all codes within ICD-10 that are priority codes that actually are billable now. And they're thought of, and many of them are billable under enhanced care management. They're the kinds of things we think about people who are living their lives and are in desperation. They don't have enough food, they're homeless, they're unsheltered, they have food insecurity, they have insufficient social insurance and welfare support. Housing becomes an issue. All of these, the California understands that to provide health you have to make sure that the social determinants are taken care of. That is a big effort. You see it in ECM. You also see it in being able to bill for other kinds of things that are supported. I really think for providers and those who contract with counties, the codes that I've just listed and earlier, what we've talked about here in terms of CPT codes and now SDOH code, see what the counties are paying for. And you can start making some cases for and managed care plans, making some cases for how this can serve them. Next slide, please.
Dr. Buttlaire, quick question for you. I mean, given that this is so new to us here, do you have any specific recommendations or things that you think providers really need to consider when addressing the social determinants of health in a treatment or care planning from the health system perspective, in terms of how these are important to you and what you would expect from a provider?
Well, ECM specifically actually includes many of these under ECM and the codes. I would ask, as I said earlier, a couple of earlier slides, think about what you're doing now. What are you doing? What are you providing now? What kinds of transportation services are you doing? What are you identifying in the patient populations, and then making sure you're contacting the mental health plans as well as the managed care plans under those codes, and see whether or not they're billable codes to be paid for some of the things you're already doing. I really do think that a lot of the provider networks now are doing a lot more than they're getting reimbursed for. And now there's potential to be able to get reimbursed for things you're already doing, you already are experts at, that may not you may not have thought about before. So looking at these kinds of things and these codes, I think that really will help target you in terms of your thinking about your staffing and how you do staffing as well.
Mm-hmm. Mm-hmm. Thank you
Any
for
other
that.
comments? Dee, do you have any comments about that, or Richard, any more comments?
Well, I think, I mean, one thing that comes to mind is since we're talking about the new codes for social determinants, and we're in the midst of the transition here in California of implementing the new CPT billing code system that is supposed to go live in January. I guess I had a question for Dee. And Dee, what should providers be doing right now to prepare for kind of more at the operations level, to prepare for this CPT code billing transition, because it's going to change the way we bill using Z codes, using CPT codes. Any thoughts?
Sure. One of the things that I think is going to be very key is going to be, and this relates back to Stuart's comments, is not just auditing what you're already doing, but going back and having a robust training opportunities with staff, because use of CPT codes are going to be very different than what many are used to when they're billing and documenting by the minute. Over and above that, though, having a very clear understanding of your unit cost, and not just your unit cost overall, but your unit cost by provider type. Those are those MDs, NPs, LCSWs, and so forth that Stuart mentioned. Being able to understand that is going to be critical. One of the things also in looking at the CPT codes is that the current codes that are used in the state and counties, particularly the counties right now, don't necessarily translate cleanly into a CPT code. It's not a one-for-one in terms of the type, in terms of the service that's provided. So understanding what the CPT code really is telling you can and cannot do compared to what you're used to doing is extremely important. And then lastly, which I think has been touched on, is making sure that your EHR, your billing platform, which I strongly recommend if you don't have it, that you consider a electronic automated billing system. and then that those tie into your general ledger. So this is a really good time to perhaps be looking at, for example, your billing system and whether or not you want to update that now going into this change, rather than catching yourself utilizing a system that simply does not keep up with these new changes.
One of the nice changes that's going to be happening is everyone hates the Medi-Cal documentation system and how that relates to billing. Going to CPT codes changes things from having to bill by the minute and document by the minute. So that's going to be one of the nice changes that's going to be happening in the future. It's really important, going back to what Dee's saying, all these pieces need to fit together. But I do think you really need to do this analysis and this crosswalk between what you're doing now, who's providing the service, how it qualifies under the CPT codes, and how that would translate into the CPT code world, and then looking at that staff mix. What is your staff mix now, and how is that billable, and how can you change if you need to in order to both produce better care, quality outcomes, which I think is the important point, but also getting paid for what you're doing, which I think is really important now, is you have to be thinking about your bottom line in terms of dealing with managed care plans, as well as the county mental health services as well. If you go back to May of last year's DHCS billing coding, you'll see an enormous number of possible billing codes for services. That's a really good place to look at also. At the number of codes that are listed there for the services that are provided. Some of the translations are there also from HCPCS to the CPT codes, and then have those conversations with your mental health plans about what you want to provide, because some of those are going to need to negotiate. Not every county is going to accept the same CPT codes. So you have to pick and choose who you want to work with, which counties you want to work with, and also make the case to the county about how that's going to save them money as well as provide better care. So there's a lot of things to think about here related to payment reform.
Thank you.
So no wrong door. This is an idea that was discussed quite a bit in our stakeholder groups. What we don't want are people to be sent away for services. We don't want people to be directed away from care. We want to make sure that people get services without delay, regardless of whatever delivery system they're seeking the care at, and are able to maintain treatment relationships with trusted providers without interruption. We don't want to have situations where people are in the middle of care and suddenly they've lost their care, or that they go to one system and are turned away rather than seeking services. So again, the state is trying to create a level of collaboration between the managed care plans and the mental health plans and their subcontractors that provide focus on the care delivery system. Next slide. So these are the four elements of no wrong door. Services are provided prior to determination of a diagnosis or prior to determination of whether somebody's involved in the non-specialty mental health system or the specialty mental health criteria are met. What does that mean? Well, what it means is that there's no diagnostic requirement at the front end. I'm seeing a patient. They come in, I've met them for the first time. I may not know what their diagnosis is. I may not know if they're a non-specialty mental health person or a specialty mental health disorder. It may take me a few sessions to figure that out. This allows you to bill, excuse me, provide services first, and then worry about billing whichever system they need to go to. So if you're in a managed care plan and you see somebody and you determine that actually they have a specialty mental health service according to the state, you're able to bill the mental health plan for those services. If you're with a county or a county provider, you're evaluating the patient. After 2 or 3 sessions, you determine the patient is actually non-specialty mental health services. You can turn around and you can provide bills to the managed care plan. That's the way this is supposed to work, is that collaboration, that the patient comes first, figuring out what's going on with them. And it may not be that first meeting that you have with that person. It may take a few sessions. So that's what the thought was about this. Then the second one is about services are not included in an individual treatment plan. And those of you who know in the Medicaid world, if you didn't have it listed in the treatment plan and then an action for that specific thing, you didn't get paid for it. But what happens? The patient comes in, you're treating them for depression, and this next session they don't have any they need supported housing. So you can provide services outside of what the treatment plan is, because people change, and the treatment plan isn't in stone. Treatment plan has to evolve with patients' needs. So that's why this was put in terms of no wrong door. Then the third one is the member has a co-occurring mental health condition and a substance use disorder. So the person has a co-occurring condition or mental health disorder, and they can have both. They can actually be provided, their mental health services can be provided at the same time, maybe not in the same place, but the same time as they have a substance use disorder. So what does that mean? So as we said earlier, substance use disorders are carved out of the managed care plan. I'm in a rehabilitation program and I'm depressed, and my depression is mild. That person is eligible for services in the managed care plan. They have a co-occurring disorder, they have a mental health disorder, and they have a substance use disorder. They need both systems. Additionally, somebody could be treated for their mental health condition, and during the course of their care, you determine, in fact, hey, they've got an addiction to drugs. So they are eligible for both services at the same time. A lot of conversations about those systems, the substance use disorder system and the mental health system, people being sent away. Oh gosh, Joe has a mental health disorder, but he's using drugs, so we can't treat him. He's got to first get his substance use disorder taken care of. That's not the way things are supposed to work now. In fact, you should both treat both disorders. There are still some obvious nuances to that in terms of our ability to determine whether or not somebody has a mental health disorder if they're addicted to drugs, and similarly going the opposite direction. But irrespective of that, we're supposed to be treating both disorders concurrently at the same time, including people who have really significant mental health problems, who have a serious mental illness. They may have a bipolar disorder and also have a substance use disorder. In that instance, the substance use system should be treating that person, as well as the mental health plan should be treating that person as well. Similarly, number 4, non-specialty mental health and specialty mental health services are provided concurrently. Somebody can have both a problem with their non-specialty mental health condition. They can be depressed, and they also might need intensive case management that the county might have as well. They may need supported housing. They're coming in for their non-specialty mental health disorder, but they may need services that the county can provide. So the services are to be provided concurrently, coordinated. Again, this concept of coordination between the mental health plan and the managed care plan, and not duplicated. What does that mean, not duplicated? Well, somebody can't have individual psychotherapy in both systems. They shouldn't be provided drug management in both systems, medication management in both systems. seeing 2 psychiatrists in 2 systems for their medication doesn't make sense. So again, you don't want to duplicate those two issues, and you may have to again coordinate each other, and that's not so simple, is it? Coordinating systems between the managed care plan and the mental health plan is not easy, since they're not on the same electronic medical platform. How do you get information back and forth? Well, the state hasn't resolved that issue. I know that managed care plans are trying to resolve that, as well as counties are trying to be, but even the counties are on different systems. So it is complicated and difficult. The managed care plan is supposed to be accountable for ensuring the fact that people are getting the care in the mental health plan. So there's a lot of conversations going on now is, how are we to assure that that person is getting care in the mental health plan from the managed care plan's perspective, since we're not on the same electronic medical record platform? Do we need to call the patient multiple times to find out whether or not they've landed in the mental health plan? Do we need to create some kind of electronic portal between the managed care plan and the mental health plan and their subcontractors? We have to be able to assure that people have been getting treatment. That's been a real problem. It's been a black hole. I know from my perspective as a leader within our system, when we send a patient off to the county, I don't know whether or not they're actually getting the care that we've actually wanted them to get. And sometimes there's not the ability to get that information from each other. Barriers have included things like having a release of information, for example. So those are the kind of things that I think need to be worked out. And one of the ways they're being worked out is in the MOUs that are being developed between the managed care plans and the mental health plans. That should be a focus. That kind of collaboration between the managed care plans and the mental health plans really needs to be worked out between the 2 systems under no wrong door. And the state's going to be coming back and asking lots of questions from both the plans as well as both plans, the managed care plan and the mental health plan, about how they're coordinating services between the systems. Other comments, questions? Richard, Dee?
You know what, I mean, one comment, I think we're seeing, and we have started seeing it in the last year or two, providers starting to position themselves in creating delivery systems that are no wrong door, either through strategic partnerships with other stakeholders in the community, or providers. I don't think they'll mind me mentioning their name, Tarzana Treatment Centers here in Los Angeles County, where they have their entire program model is based on an integrated care, whole person care, no wrong door system, whereby if you come in, you're assessed and will get treatment for behavioral health, drug and alcohol, and primary care. If you come in the mental health door, you're going to be assessed for the co-occurring, SUD services you may need, and everybody is assessed for primary care. And so I think we're starting to see more and more of those kinds of models that are being set up, so that when clients aren't falling through the cracks, and we're able to address all of the different needs they have, and especially that link to primary care. So I think that's a good thing.
Yes, Stuart, earlier you mentioned that, for example, with CPT coding, that with documentation, at some point, we're going to be glad that we made that change. Like CPT coding, and now talking about no wrong door, I think ultimately it's going to improve the system. The pain point is the transition from where we are now to reaching that end goal. One of the things that I know that we're spending a lot of time talking about with providers is how providers start to develop internally their own care coordination capabilities as they expand from working with, for example, historically, perhaps just with the county system, and expand to a broader array of providers that include the health plans. That care coordination is important as they do that, just as it's important in thinking about whole person care and requirements of seeing individuals, not just referring individuals, but seeing them to, for example, a primary care provider. That same care coordination could be a stopgap while counties and health plans are developing their systems over time. And it may be up to the providers to think about how do they assist with that care coordination, that communication, since they're on the front lines treating these individuals.
Yeah, those are really good points both of you are making, and it's critical that managed care plans are ultimately responsible, and the state is really focusing more and more on managed care plans, making sure that they're coordinating, they're putting more of the onus on the managed care plans at this point. So if you're a managed care plan on this call, really be thinking about how are you doing your care coordination? Are there some best practices that people need to share among themselves? Can we work together to really think through what are some of the better ways we can go about that in instances where we do have electronic medical records and we can coordinate things, and where we don't? And how will we navigate those systems? Again, I do want to underline this concept of having to make sure that care is being delivered. It's not just enough to throw something over the wall and expect that patients are going to be cared for. You have to know that the patient actually has arrived and actually has been engaged in the other system of care. And that's a tough issue that has to be worked out. And I'm working with another organization even outside of Kaiser right now to talk about what are some of the things they can be doing, going in either direction to work with managed care plans. Next slide. So we have the new screening and transition tools, and those are requirements now to transition a patient from the managed care plan to the mental health plan. I'm not going to run through all these the words here, but I want you to understand that in the Medi-Cal system, and this is a little different than in the and some of the managed care plans, a youth is up to age 21. Many managed care plans think of adults as 18. In the Medi-Cal world, somebody is still a youth up to age 21. So the screening tool has two tools, one for youth and one for adults. The youth one has actually two parts of it. One is when the youth is seeking services, and the other part of it is for the parent who could be seeking services in the name of the youth. And then there's the adult tool. Both of the tools are really nice in terms of asking questions. They're, again, for new patients, not patients who are already assessed and being seen in your system. And it really was designed for non-professionals. 800 lines. A lot of managed care companies have 800 phone lines where you're calling up and somebody's saying, I really want to see a therapist, or I want to see a doctor. And there's a list of questions that are very straightforward, very easy to answer, very easy to score, and they have a rubric at the end, really nice to be able to say somebody scored 0 to 5, therefore they're in the mental health plan. If they score higher than that, they're in the mental health plan. If they score 5 or less, they're in the managed care plan. There's a rubric, so you can actually work through that and then send that information off to the other plan. That's nice, and it does relate to having the structures of our way we go about screening patients now. The rubric was very important to be able to design that, and wanting to keep people in the right system. at the right time, so they're not having to go through back and forth. So that's a nice tool, and that should be really worked out between the managed care plans and the mental health plans. I know 2 of the counties that I work closely with, it's actually gone back and forth extremely well. The other thing I want to mention about the screening tool is, again, underlining the fact that you do not have to have a professional doing that. It does not have to be a licensed professional. It can be front office staff, it can be administrative staff. Train them, of course, on the use of the tool and go through that with them, but it's not a specialized tool. It wasn't designed that way. It was really designed for the average administrative person being able to administer it. Excuse me. Next slide. The standardized transition tool, lots of conversations about this one. This is somebody who's already been assessed, seen in either of the systems, and is determined to be mild to moderate, therefore is in the mental health plan. And if they're severe, if they're severe, they're in the mental health plan. And if they're mild to moderate, they're in the managed care plan. When we first designed it, the work group, we did have a rubric, just like we had for the screening tool. At the last minute, I think last August, DHCS determined the fact that the rubric was going to be removed. And so that, again, is leading to, and I was not in favor of that, removing that rubric, and several of my county colleagues were not in favor of it as well, because we know that it's pretty obvious to see who's mild. It's pretty obvious to see who's severe, but that middle group leads to a lot of back and forth conversations between the managed care plans and the mental health plans. The rubric really helped differentiate and was a good, and the state determined that really for consistency's sake, they wanted to not do that. There's a lot of information on that transition tool, a lot of clinical information that's required, all the services that the patient has, their history, medications that they're on, and then thinking about that other system of care and what services they require. I'm seeing Joe, I'm working with Joe, he has he's depressed, and suddenly during the course of care, he becomes more ill, needs to have more intense, intensive care. I have to list all those things and my reasons, and then point out what services he might need with the county. Is he going to need some kind of coordinated care, managed care? Is he going to need some kind of residential program? That would be what we would look at. On the other side of the coin, somebody's been seeing post-psychiatric hospital. They've been in care. Now they've been treated. And now they're on their medication management's going well. What they need is they need more psychotherapy and they need medication management. They're now moderate. So I need to list all those things and then let the managed care plan know, Joe really does need to have medication management and individual psychotherapy. He's eligible for those in the managed care plan. So those are the things that the transition tool really will provide. It lists a lot of information about that person, what services they've had, their hospitalizations, their medical conditions, their comorbidities, and it helps really for those conversations going back and forth between the counties and the managed care plans. Important to be able to understand that. I've gone through that in our system, talking about how to use that. It takes some time to have to think it through, also to have conversations in terms of, again, coordinating care, because you don't want the patient to be stuck in the middle, right? While this is going on back and forth. It is the system that the person's in at the time of that transition tool going to the other system. That system that they're in continues to provide services till there's actually agreement that the patient transitions. That is something that people need to be mindful of. It may be, not everybody has all the elements of services. I know in our system, Sometimes when we transition a patient to a county, they may not have a child psychiatrist appointment for a month. We continue to provide the care that the person needs until we can transition. Supposedly, we're supposed to be able to bill the other system for those services while that patient is seriously mentally ill. Going the other direction, similar kind of thing, being able to bill the managed care plan if you're providing mild to moderate services for that patient while they're trying to get them enrolled in the other system. So keep that in mind, why documentation is important, why coding is important, because you will be able to bill the other system based on the patient's condition. Other comments from Dee or Richard?
Not at this time.
Okay, so moving on then, so we're going to ECM populations. These are populations of focus. In pink is the counties began implementing ECM in July of 2022, making ECM statewide. It's really now statewide. It's statewide. It includes individuals and families experiencing homelessness, adults at risk of avoidable hospital emergency department utilization, adults with serious mental illness or substance use disorder, individuals transitioning from incarceration, individuals with intellectual or developmental disabilities, adult pregnant and postpartum individual at risk of adverse outcomes, perinatal outcomes, excuse me, adults living in the community and at risk for institutionalization, eligible for LTC, institutionalization, adults who are nursing facility residents transitioning to the community, children, youth, populations of focus beginning later this year and eventually to January the 1st, pregnant and postpartum individuals at risk of adverse perinatal outcomes who are subject to racial and ethnic disparities, and individuals transitioning from incarceration, and you see the dates on the right. Next slide. These are the types of supports that are supposed to be available within ECM, Enhanced Care Management. There are 14 of them. Managed care plans do not have to provide all of them. They can pick and choose and make a determination within their system. They had to go to the state and get approval for that. And really, the community services are flexible wraparound services that managed care plans would integrate into their population health strategies. Should be part of their strategy, and provided as substitutes to avoid other Medi-Cal covered services such as ER utilization, hospital, skilled nursing facility admissions, or a discharge delay. So what's the concept behind this? The idea is really to substitute for much more expensive facility-based services. If we can provide things in the community, if we can, again, deal with those social determinants of health, people will not need to end up going repeatedly into the emergency department. Will have managed their care better. And so that's really been the cost-effective alternative to services under the state plan. And hopefully the state's going to be looking at some of the high utilizing individuals and determining whether or not this is actually paying off in the long run, actually reducing those facility-based costs and utilization. Next slide. Sometimes we have so many different case management programs, and so I wanted to let you see what the pyramid is in my mind for the CalAIM care management continuum, from really basic population health management that everybody should get. All PCP, all managed care plans should actually have preventative measures to ensure that people are not going to have cancer, are being screened for substance use disorders, are being screened for depression, are being screened from other types of illnesses, and making sure we're vaccinating whole populations. That should be part of the basic health management population. Then complex care management is really about targeted case management for individuals with diabetes, CHF, COPD, other types of disorders that people have. So they're already ill, and we want to manage their care in such a way that they don't have increased illness burden. And then there's the enhanced case management, which is the top. These are people for the highest need members who are using lots of resources and services, and we find that they really do have really lowered social determinant of health problems. Next slide, please. This is how this lines up in terms of adults versus children. The children and youth are coming in later this year and early next year, but you can see all the different 10 populations that I mentioned a little bit earlier, the populations of focus, and some of the differences between the two populations. You can see 7 and 8 are really focused on kids and youth in child welfare and CCS, or whole child model. And then on the adult side, of course, adults at risk in the community for LTC, institutionalization, and nursing homes. Next slide. Here's an example of the elements for enhanced care management for SMI and SUD people. The definition, of course, is the Medi-Cal benefit that aims to address the clinical and non-clinical social determinants by providing intensive services, including multiple touches. Members are identified via data mining or by referral. Eligibility includes youth, adult high utilizers, adult SMI, SUD population, and the care plan that has to be addressing those clinical and social needs. Next slide. Here's an example in terms of how it's rolled out in terms of adult populations for SMI and SUD. Eligibility, services through county specialty mental health or drug Medi-Cal, and at least one of the complex social factors, again, those social determinants of health, lack of access to food, lack of access to stable housing, etc. And meet one or more of these criteria. They're using institutions, they've overdosed, they're suicidal, they've used crisis or emergency room urgent services, they're experiencing lots of ED visits and hospitalizations, and are pregnant or postpartum. So all of those things go together in order to focus on and determine what that population is. And each of those elements that we describe populations of focus should have criteria, and providers should know about that. A lot of efforts going into contracting at this point to be able to target those populations. And last but not least, the last slide, we're coming up on time, is really children and youth. This is what's coming up next year in particular. Is much wider ability to provide services by mental health plans, as well as drug, and making sure that these youth who are subject to homelessness and other issues are getting the required services and care management that they need in terms of this ECM. And then later next year, next slide, is the transition to individuals from incarceration. That's going to be for both adults and youth who are in the custody of correctional institution or coming out of a jail, keeping in mind that they're 18 to 21-year-olds are oftentimes in jail, not in juvenile hall. So both systems need to provide that kind of transitional care for the youth. And I think that's through the slides. And do we have any time for questions?
I'm gonna see, we're down to 1 minute, and maybe I'll just real quickly check with Corey if there was any questions in the chat.
Hey, Richard. Yes, we had a couple questions, and I want to let everybody know we're going to follow up on these later. Latest question from Barbara: what if you're doing evaluations of homeless individuals who have Medi-Cal but don't agree to services? Can you still bill for the evaluation?
I couldn't quite hear. Did someone else hear it? I couldn't quite hear.
You were low, Corey, you're a little low volume.
Well, let me try that again. What if you were doing evaluations of homeless individuals who have Medi-Cal but don't agree to services? Can you still bill for the evaluation?
I would think you could. I would think you could for the evaluation. Absolutely.
And we have a
They may
couple
refuse
others here,
this-
but
They may refuse the next level of care, but again, we're not supposed to be turning people away. So you're doing an evaluation, you've determined that the person is homeless. You want to link them up with services, both mental health services, and you may have some other ECM services that you want to bill for. I think at that point, yes, you probably should try to build either the managed care plan or the mental health plan, depending on what you've determined the person's illness burden to be. I hope that's answering your question.
well, we will follow up, and I apologize. We have come to the top of the hour. Dr. Buttlaire, thank you very much. I know you have another engagement to get to. Richard, Dee, thank you very much. For everybody who joined today, I want to let you know that we will be here again next week for our next roundtable, Developing Innovative Collaborations for School-Based Mental Health Services, the Emergence Health Network case study. I also wanted to let everybody know that the recording for today and the slide deck will be available on the Open Mind website starting tomorrow. With that, guys, thank you very much, and I hope you have a great day.
Thank
you,
you.
everybody.
Bye, everybody.
Bye-bye.
Thank you. Bye-bye.